Hello, everyone. Today I talk about the multi-system trauma, especially trauma in pregnancies. So something new, some updates about the multi-system trauma. Okay, multi-system trauma. When the patient comes to emergency department, we randomly surveys which simultaneous resuscitation, secondary surveys, and after that we evaluation. So remember airway, breathing and ventilation, circulation, hemorrhage controls, disabilities, exposures, and remember initial approach. We do is the same time, vital signs, pulse, blood pressure, temperatures, SpO2, HCG. You said to lab intravenous line, blood test. Don't forget about the myoglobin, blood gauge. Blood gauge is very important. And pain relief, we used to use one list ringer task, and if the patient still hypertension, we use blood transfusion. Air fast, stomach assist, stomach and urine tip, dark and dark red urines. We do X-ray bedside or CT scanner, the history of anticoagulation, hip one, and the most important is teamwork. In EMC, we have a cord red. When patient we had the multi-system trauma, we call the cord red. Then all the doctors specialists about the neurologies and all doctors come in emergency to examine the patient. About the volumes resuscitation, we not about the aggressive and continued volume resuscitation is not substitute for the definite control of hemorrhage. And with a polar one list of isotonic solution may be required to achieve the appropriate response in the attent patient. The fluids are immunity. If we transfer more of one list isotonic solution, this increase mortalities and morbidities. One study about evaluate trauma patient received the fluids in the 80s for that resuscitation more than 1 to 1.5 list independently increase the odds ratio of death and some and about the pain relief, we had 3 degrees. We had 7 to 10 marks. We used the opioids, fentanyl, and mixed some drugs, the gabapentin, pregabalin. About China Smith assist. We actually choose bruise the transmission is very important for the patient. Within 3 hours injuries, and when the bolus and the field follow-ups infusion is given by over 8 hours in hospital, then you should remember the training as submit assist is very important for the patient. Airways maintenance. Airways signs of obstruction, thermal injuries, inability to protect airways. If the patient has large growth to below 9, use anesthesia brush. Evaluation of endotracheal intubation is difficult to repair equipment. It was in the one brush for intubation live videos. This is the choose pictures we can do in the emergency department. The chin lift and the charge rush. If the patient is the child, we can move the plan of the face in the parallel in the spin bar. We protect the cervical spin during airway controls. We will remember the spin motion restriction techniques. You see that? And when the patient needs to intubate, we have to choose doctor, one doctor intubate, one doctor to retrieve the next. Leaving the collars in the space region in the restriction of mouth opening to 20 millimeters or less. Therefore, this patient cervical collar should be removed while inline cervical immobilization is maintained. This when the airway management is necessary, the cervical collar is open and the team members manually retrieve motion of the cervical spin. And we have four doctor choose remove the handbar as soon as possible, because we use the patient in the handbar for about 2 hours. Maybe the ulcer skin. Predicting difficult endotropy and intubation and tools and medication. We had the layman's solution to still predict the difficult endotropy and intubation. This modified layman score is correlated with difficult intubation in alien trauma patient. This is look externally, malabody glass, obstruction, next mobilities, and evaluate 3-2. This is the evaluate 3 I usually used in the emergency department. You see 3 fingers in the mouth, 3 fingers between the mentum and hyoids, 2 fingers between the hyoids and the larynx prominence. To read difficult intubation, we can repair the guide wire. We can the buoys, the gum elastic buoys, choose guides and intubate. And when the patient has very difficult, we can the surgical so-called thyroidotomy. The techniques of brush and system intubation is a lot of flows. We have the plan in the even fellow to that includes the possibility to perform the cervical airway, ensure the suction ability to deliver positive pressure ventilation. Use source when remember we oxygenate the patient with 100% oxygen, apply pressure over the sarcophagus, and this is very important. We use the induction thrust, etomidat or ketamine, because etomidat and ketamine is not effect to the hemodynamic. And after you use intubation, we use the midazolam and fentanyl for the patient. About the breathing and ventilation, adequate surface options, monitoring breathing rates, SpO2, SpO2, blood gas, look for slides, tetanus, intrathoracic lesions, clinical sign, fast X-ray, obstruction of the airway, pneumothorax, hemothorax, open pneumothorax, flare chest, and pericardial hemorrhage. You see, we have the two kinds of the pneumothorax. It is about the pneumothorax, and this is the open pneumothorax. The new updates in the new updates and the that for the agent, especially with the thick occur the subcutaneous, we use the fourth and the fifth intercostal space anterior to the mid axillary lines. And we check the tip, chest tip, 28 and 32F. You see, if the patient had open pneumothorax, we glue the three X of the wound and lay the check stiff removed from the wound as soon as possible and send the patient to the operating room. About the pneumothorax, this is the new recommendation. Refer size fourth and fifth intercostal space, anterior ancillary line. And if the patient had a serious case, we can use the finger decompression. The tension pneumothorax can be managed in clinics by rapidly applying the finger decompression technique. Hemothorax, the most important when we raise the chest tips with the chest tip at the fifth intercostal position, just anterior to the mid axillary line. Open chest when the instant blood out 1,500 milliliters and blood out 200 milliliters per hour for 4 hours. This the patient needs to operate open chest surgery. About the flare chest, it's very difficult to reduce the active pain relief. And about the explain lung volume, we do to practice entry reading with the spirometry. Spirometry is the instrument help the patient respiratory deep breathing cough to reduce the secretion and prevent the atelectasis. Consider NIF and intubate the patient. If the patient has the low oxygen. Air fast, as you know, air fast is very important in the patient in the trauma. We can check the patient in the dormant lung and cardiac. We had the fluids and the submersion slide. We had the fluid and the lung. We had the fluid and the spleen. We check the cardiac. We check the cardiac. It had the fluids and the cardiac. The bladder. The fluids in the bladder. The last. We can check the
exam type is used to evaluate lung sliding. The anterior, lateral, and posterior zones of the chest wall should be evaluated.
The lung slide is normal. We check. You see, there is no lung slide. This is the head patient pneumothorax. And we have the M-SMOS. and most we had a seesaw sign. You see, big weight, big, and then if have no seesaw sign, the patient had the pneumothorax.
Exam type is used.
About the circulation with hemorrhage controls. With a diagnosis, you use based on the vital signs, blood gas, and fast hemorrhagic shock, most common chest, abdomen. Shock without blood loss about the pneumothorax, cardiogenic shock, or acute cardiac tamponade, neurogenic shock, damage to the brainstem, the cervical, spinal cord, or upper chest. Septic shock. Septic shock is the later phase. Blood transfusion ratio 1:1:1. Hemostasis. We use tranexamic acid, procedure, surgery, antagonist, and conscious metabolic acidosis, hypothermia, and coagulopathies. Hemorrhage is a key loss of circulating blood volume, although it can vary consider normal iron blood volume. It's approximately 7% of body weight. In the patient obese iron, we estimate the patient on the antibodies because the control based on actual weight can estimation. We usually use the task score to evaluate the patient, choose reduce the lab volume blood transfusion. This is the table, the task score. You can use the MB con to task score to reduce a small success of patient with shock with required massive transfusion, most often defined as over 10 units and also more than 4 units in hours. Early administration of red blood cell, plasma, and platelets in the ratio 1:1:1, because from today's we use the 1:1:2 ratio group. The faster hemostasis achieves in 1:1:1 group, no difference. So it's 1:1:1 is very good for the patient. And about the task score, with about 50% of this massive transfusion was reached by score 16, and the score of waiters 27 was 100% reached of this for massive transfusion. About the fluids and blood resuscitation, restore organ perfusion and tissues oxygen stations. The solution of restoring blood bolus to replace lost intravascular volume. The patient of blood pressure rise rapidly before bleeding is controlled. This causes the more bleeding. So remember, we can accepting a lower than normal blood pressure, head windstorm, control resuscitation, balanced resuscitation, or hypotensive resuscitation. We don't need transfusion. We can use many flush isotonic to raise blood pressure, because blood pressure rise rapidly. It is more bleeding. After during resuscitation, we should produce the urinary output of approximately 0.5 minutes per kilogram per hour in adults. The patient early hypovolemic shock and respiratory cholecystitis tachycardia is frequently followed by metabolic acidosis and does not require treatment. However, such metabolic acidosis can develop a long-standing or sub-shock. Metabolic acidosis is caused by anaerobic metabolism as the results of inadequate tissue perfusion. So in at the rest, recommend do not use the sodium bicarbonate to treat the metabolic acidosis from the hypovolemic shock. So but and up to that, we check if the patient had the pH less than 7.1, it's reduce the left ventricular contract and arterial vasodilation and impairs the responsiveness to the catecholamines. So the FTS recommend to the going up bicarbonate therapy in the patient with lactic acidosis and acidosis to the pH was below 7.1. When we use the peak bycast, we get the 1 or 2 meth per kilogram is the intravenous bolus. And the newspapers, the review, we can recommend that treatment is the bycast should be researched for the cardiac arrest patient in one or follow forward safe acidosis with arterial pH below 7.1 and pH test below 10. The patient with prolonged cardiac arrest related hyperkalemia and cardiac arrest related to the overdose of tricyclic antidepressant. This is compares the table compares the TBL fast CT scanner and in the patient in in the patient with the trauma come to emergency department with the hypertension. You should call the Red Cross or teamwork should decide to check to transfer the patient to check the CT scanner. We transfer the patient to check the CT scanner with the normal hemodynamics, and the patient penetrating back flank trauma without other indication for immediate laparotomy. So with the patient hypertension, we should resuscitation with fluid and blood transfusion first. With the patient in normal hemodynamic, we transfer to the CT scanner. Hemostasis procedure and surgery. We use the tranexamic acid, anticoagulant antagonist, kidnap, tonic, spleen, pelvic compress, and the pelvic fracture, ensure embolism. Monitor of compartment syndrome, myoglobulin due to rhabdomyolysis. And about the tonic is the grade 2C, and in the military and the civilian experience with the hospital and emergency department, tonic application has shown that the liquid is safe life with the flow rates of complication. Stop the bleeding. We apply the pressure with hand. Choose, we apply the breast and breast. Cheese, we apply the tourniquet. You use the breast, swing, and lock, secure, and each time. This is the pictures. We use the tourniquet. If the patient had the fracture, the gone up in the fracture, immobilization is like the insurance extremities in the edge close anatomic position is possible to prevent excessive fracture side motion. If the time to operate intervention is longer 1 hour, a single attempt we can deflate the tonic pressure maybe to consider in an otherwise stable patient. The risk of tonic pressure is increased with time. if the tourniquet must remain in the play of the prolonged period to save a life, the choice life over the limb must be made. And we can keep the tourniquet in the play for 2 hours and more if necessary before onset of potential irreversible muscle, nerve, and tissue damage. Upon pelvic fractures, we suggest operate the control of hemorrhage using external blockers, fixation plus surgical angio embolization may be required to control the internal hemorrhage. The priority is to stop the bleeding, not to control the volume of the fluid loss. Maybe we usually control the pelvic fracture loss about 2 liters, 2.5 liters. We transfer the blood pressure. So the new guidelines recommend the priority is to stop bleeding, not control the volume. The hemorrhage is the major potential reversible factor to contributing to the mortality.
Underneath the knees. Okay, make sure you got the right edge. Okay. Right, and just pull it against yourself. Pull a little more toward you. Yes, okay.
It's so helpful.
Down?
Yeah, I guess the things are just yeah, take out your time and then okay, there's sorry.
You like those bags? Oh, you're playing with my light. Blue light in the back doesn't work. It has a light in the back so your buddy can follow you.
Oh,
and so we have spot signs like that.
We tuck and we'd also tape just to make sure it stays. Make sure all the ends are tucked in. Tape across it.
And about the anticoagulation reversals, we had the tables. If the patient had the aspirin, warfarin, heparin, sarentos, we have the comment here. About the spinal cord trauma, with the patient failures of fluids, resuscitation to restore the organ perfusion and tissue oxygenation, suggests either continuous hemorrhage of neurogenic shock. We can use the Canadian cervical spin rules on nurses to assess the patient to need to check the CT scanner. And remember that the news, the update at the West about the spinal immobilization to move spinal motion restriction, because you're using the handball for more than 2 hours has the risk of skin ulcer. About the new neurogenic shock, venous spinal shock, to remember about neurogenic shock, it is the position, the upper thoracic spinal cord T6 and above. The patient loss of simultaneous innervation to the heart can cause bradycardia and at least inability to mount tachykinetic response to hypovolemic. And so these serious use of vasopressor may be required after moderate volume required and atropine for the patient. And you use surely the patient have no hemorrhage before you use the vasopressor to raise the blood pressure for the patient. Because you remember us, we use the rise the blood pressure quickly, it is the more hemorrhage. And spinal shock refer to the facility's loss of muscle tone, loss of reflex, and occurs immediately after spinal cord injuries. About the disabilities assessment of neurologic status, about the traumatic brain injuries. Glasgow control blood pressure, PCO2, preventing conservation, spine injuries. This is the patient's cone fractures. We have the hemotympanum, the cone eyes. The trauma. We had a table give the ground of the treatment of brain injuries, which is focus to the blood gauge BiCO2, the maintain and the blood pressure, the maintain systolic blood pressure at about 100 the patient 50 to 69 years old. About barbiturates and anticonvulsants, it is not indication in the acute resuscitation phase, because barbiturates should can cause the hypertension or hypovolemia. Barbiturates is not recommended for preventing late post-traumatic seizure, when the overall benefits of is fair otherwise of complication associated with such treatment. However, early post-traumatic has not been associated with worse outcome. Intravenous fluid, glucose-contained fluids can cause the hyperglycemia, so it's not recommended. Ringo solution and normal saline is recommend for resuscitation. And about the mannitol and hypertonic saline, mannitol, we can don't give the mannitol and the patient with the hypertension, because mannitol does not lower ICP in the patient with the hypovolemia. Hypertonic salines can use for the patient hypertension. Exposure about the patient healthy with the burns, respiratory control injuries that are easy to miss in the back, arm bridge, Freud. With the patient get burns, we use ringers like that, CO poisonous myoglobulin. This is the night rule, the night other patient burn in the children in the island. Degree of burn fluid resuscitation. You usually remember about the patient need pain relief, anesthesia, and infusion before infusion regular task antibiotic. We should infuse regular task before transfer the patient. It is we have the principle to control the regular task for the patient. The transfer the first 8 hours, and after that the half we transfer infuse for subsequent 16 hours. To the tables in the adult and the children, we use the and we follow the urine outputs when we infuse regular tasks and follow the urine outputs. This degree of burn and transfers the patient. We had the hands. Especially about electric burns, includes planning injuries. Any the patient with burns contain concomitant traumas, and with the burn injury pose the greater risk of morbidity and mortalities. In such case, if the trauma poses to the greater immediate risk, the patient may be in need to stabilized in the trauma center before being transferred to the burn units. The physician's treatment is necessary to such situation and should be considered to consult with the regional medical control plan and treat protocol. Frostbite, we have 4 degrees: no frostbite, frost slip, superficial frostbite, deep frostbite. This managed and frostbite and non-breathing injuries. In the treatment, we choose the replace the constriction and hot fluid by mouth if the patient can screen. Later, the injury packed into the circulating waters at the constant 40 degrees Celsius until pain controls. The treatment is best accomplished in the patient setting in the last tank, such as the whirlpool tank, or by bringing in the injured limb into the pockets with the warm water running. And remember that 1 minute of last areas can result the reperfusion syndrome with acidosis, hypokalemia, and local wet swelling. Hypotonia. With the patient hypotonia, cardiac output fall in proportion is decreased hypotonia, and cardiac increased abilities begin to approximate 33. Ventricular fibrillation becomes increased when the temperature below 28 and the temperature below the 25 asystole can occur. And you remember that this is the term about remember the axiom: you are not dead until you are warm and dead. Oh, this is special consideration in the traumas, the pregnant patient. This is the important part. When the pregnancies come to the emergency department with the traumas, we optimize outcome for the mothers and the fetus. Clinicals must assess the resuscitate the mother first, and then assess the fetus before conducting a secondary survey for the of the mothers. And remember, concerns with the doctor specialist about the pregnancies after this treatment as soon as they know the patient is pregnant. This is the mechanisms of injuries and distribution of lung and penetration of the injury in pregnancies. We had a 91% difference and 49 of motor vehicle collision. In the pregnancy, the plasma volumes increase steadily throughout pregnancies and later at 34 weeks of presentation. A smaller increase of red blood cells volume occurs. So the reason in the decreased hematocrit level. In the late pregnancies, the hematocrit level is 31 to 35% is normal. So healthy pregnant patient can lose 1,500 milliliters of loss before its within size and symptom of hypovolemia. However, this amount of hemorrhage may be replaced by the fetal distress, is evident by abnormal fetal heart rate. This is the tables about the normal laboratory volume of pregnant and non-pregnant, with not about the hematocrit, white blood cell, and especially the BrCO2. Because BrCO2 in the pregnancy, normal BrCO2 may indicate the impending respiratory failure during pregnancy. in the late pregnancy, in the supine position, the vena cava compression can decrease cardiac output by 30% because of decrease the venous return from the lower extremities. So if the pregnancy have the hypertension, we can give the patient to the left side, look on her to the left about the 15 on 30 degrees, evaluate the price size for 6 inch about 10 on 15 centimeters, and support with the blood device, thus maintain the spinal motion restriction of the compressing of vena cava. So because of the increased intravascular volume, the pregnant patient can lose a significant amount of blood before tachycardia, before hypertension, and other signs of hypovolemia occurs. Thus, the fetus may be distressed and the placenta deprived of vital perfusion, while the mother's condition of vital signs appears stable. About the vasopressor should be actually the last resort in the last story, maternal blood pressure, because vasopressors cause reduce the uterine blood flow, resulting in the fetal hypoxia, and fibrinogen levels in the patient as in the pregnancies doubles in the late pregnancies. So a normal fibrinogen level may indicate early excess meningitis intravascular coagulation. This is the table you can use trauma in obstetrical patient and the bedside tool, position, hypertension, hypertension, vaginal bleeding, and it is very important in about receive negative or receive positive. We research treatment medication list commonly recommend about the fluids, about the oxygen, intubation, and anesthesia, antibiotics, ceftriaxone, confusion, especially receive negative, tetanus. If the patient had the blood pressure high, we can use labetalol, seizures, admission and monitors 4 hours, fetus monitoring up potentially viable fetus. And with the pregnancies had the traumas, we have with British with evaluate the hemorrhage on the abdomen. We can indicate the CT scanner because abdominal pelvic CT scanner radiation dose approx 25, the fetal radiation dose less than 50 are not associated with fetals anomalies or higher risk of fetal loss. This is the definition of immunizations. It's a little of the receive positives, thus when sensitive 70% of receive negatives. So if the patient had the pregnant of the reason the receive negative trauma, the patient should receive the receive immunoglobulin therapies unless the injuries is removed from the uterus. It shows latest distal extremities injuries So if the patient have if the pregnancy, the trauma comes emergency with the trauma in the abdomen, and receives negative, we use the receive immunoglobulin therapy should be instilled within 25 hours of injury. This is some reference about the use of trauma support and emergency medicine and up to date. Thank you. Thank you, everyone.
Thank you, Dr. Ray.
Yeah, thank you. That was amazing. That was such a great lecture. Does anybody have any questions? No. It was a great lecture. I really appreciate you doing that. One thing that I was taught a long time ago about trauma patients, and it's not like a specific recommendation. It's just something that I adopted in my practice when I see a trauma patient. Of course, we do the A, B, C, D, E. And so I first, of course, do airway, breathing, listen to their bilateral breath sounds. And then for circulation, in C, we check their blood pressure, check their pulses in all extremities. And then something that I add to C and don't delay it until like their secondary survey is to check to make sure their chest wall, I just like very quickly I say chest wall stable, feel their abdomen soft, non-tender, and then rock their pelvis and say pelvis stable. And I also just like put a hand on their thigh, on their leg to make sure they don't have a giant hematoma. The reason being that those 4 locations, like you mentioned, are the locations where someone can bleed to death and we don't know. So just very quickly, like feeling, do they have any obvious rib fractures? Do they have like a peritonitic abdomen? Do they have an obvious pelvic fracture? And if they do, go ahead and put your pelvic binder on or your sheet like you talked about. Or do they have a giant hematoma forming in their thigh? And it takes like, 15 seconds to do that. And then I go on to D, disability. Yeah. Anybody have questions?
That's very good lecture.
Dr. Dai, can you have share many experience about the patient from Chi Ray hospitals?
Always, all the day. But Dr. Hui talk about ATMS 10, so good because I have only 9. So 10 may be different, little bit different from 9, but good, very good one.
Shirley, my name Hao. Was Dr.
Hey.
I want to share some problems in emergency department for trauma patient in Vietnam. Yeah, it's the first thing. Some outstanding problem in trauma care in Vietnam. The pain relief for the patient is not enough. Emergency doctor in Vietnam don't use enough pain relief for the patient. Dr. Dai can share some opinion about that. And we don't usually use the high dose of transmit acids for the patient. If the patient come emergency department less than 3 hours. Sometimes we use transmit acids, but a low dose for compared to guidelines. One gram for the first time the patient come emergency department, but we usually just a half of dose, just only 500 milligram for them. Yes, and we usually delay certain fusion about platelets and plasma protein. We usually transfer quickly buckets of red blood cell immediately, but we delay the time for platelets and plasma. Yeah, and when trauma patient come emergency department, we usually transfusion plus for the patient and a lactate ringer or normoxanil, but we delays the time to use vasopressor, especially in spinal cord injury. I think it's a problem. It's a problem in Vietnam. And sometimes in our department the same. So but just my opinion. Dr. Dai, he can go a lot of emergency department in Vietnam, and Dr. Dai can share some opinion about something I just said to you.
I think that the dynamic is so easy though. We use the same license that we have 1 gram very easy. And after that, 1 gram for 6 hours, very easy. And we have a bucket for transfusion that red blood cell, the blast. And it's just like the packet for 331 or 111. And we have plug band in Cho Ray, so we have very fast transfusion for trauma. And we used for the painkiller, we have very high dose of morphine, something like tramadol. We use it very frequently, and sometimes if the patient go to severe condition, maybe you can sedate patient. And after that, you can, go to the OR very quickly. Actually, we used 1 gram is very easy in Cho Ray. So we are trying to do the same guideline as the US.
Yeah, I think in Cho Ray Hospital, in a specialist environment, standard environment for emergency department. But I should say another hospital is a problem. It's a problem in our emergency system in Vietnam. Dr. Dai can share some opinion about that. Not in Cho Ray Hospital, because Cho Ray Hospital is very standard for many people for learning. Okay, but I know that in another hospital, especially very far from Ho Chi Minh City, in the emergency department, I think I have some problems. Yeah.
I think the problem is when you have a black man, because it's hospital, they receive the blood from the blood bank. So when you are in Ho Chi Minh City, something like 115 or something like UC or another hospital in Ho Chi Minh City, they will reserve the blood from the blood bank of Ho Chi Minh City. So the so difficult that they reserve a lot of blood. So if you have a severe trauma come, and they come with, they need massive transfusion, something like that, they don't have enough blood to do that. So mostly just the UMC, they use the red blood cell first. After that, they consider to transfer to a bigger trauma center so that they can reserve more blood for that. And for the painkiller, that's correctly that province hospital, they don't treat it very well. So they think about if you treat so many painkiller, that means the patient going to dyspnea or apnea. Not so bad, but they treat them and they send to Cho Ray Hospital. And after that, we treat it. that's the problem about the blood bank. I think so.
Why do you think you don't give painkiller at UMC?
In the UMC, some doctor don't want to use painkiller enough for the patient because they think the patient needs to follow closely. So they when I see this situation, I usually advise our doctor to use more painkiller. But when I don't see the patient, I don't present the patient. Some doctor don't want to give enough painkiller for them. Yes. Mm-hmm. Yeah.
What narcotics do you have? Do you have fentanyl or only morphine?
Morphine, fentanyl, tramadol. Okay, it's not. I think it's enough the painkillers in our department, but I think in another emergency department, not in Cho Ray Hospital, not in UMC. Some doctor the same. I think. I think in the future, when you come back to Chi Minh City, we have a CME for just only for trauma care, transfusion, painkiller, anything related to traumas patient, especially spinal cord injury, for example. Yeah.
Yeah. Yeah, what I usually use in trauma patients for painkiller is actually fentanyl, just because it is the most hemodynamically friendly narcotic, and it's such a short half-life. So if the patient, if you give them like 25 micrograms or 50 micrograms of fentanyl, it's not going to last very long. But of course, even if you give them too much narcotic and they become unresponsive, you have naloxone, right? Narcan.
Yes.
To reverse it. So yeah, maybe it's just a lack of, like you're saying, more education needs to happen with CME and stuff.
Yeah.
And then blood. So do you at UMC, do you have a lot of blood in the hospital or no?
Okay, it's okay. I think it's enough for the patient because we don't usually receive a lot of the trauma patient. Trauma patient usually come to Chi Ray Hospital and they want to see Dr. Dai more than our Dr. Wee.
I see. Yeah. Yeah. I think like early administration of blood is so critical in trauma patients. Not using fluid. Like I know, like there have been studies that show that even giving, a liter of fluid is detrimental, is bad, and you need to start with blood. And you need to watch. I mean, if a trauma patient is tachycardic, if their heart rate is higher than their systolic blood pressure, that is a sign that you need to consider giving blood before they become hypotensive. And then you're in a situation where you need massive transfusion protocol.
Yes.
Yeah.
One thing I want to discuss with you, when the patient have a spinal cord injury, in the bath, sometimes we use corticosteroid, but now some guideline don't advise corticosteroid in spinal cord injury anymore. But some doctor in Vietnam sometimes uses. How about in your university and in your emergency department?
We don't use that in the emergency department for spinal cord injury. I'm not sure if after they get admitted and after they have, like, they're stabilized and they're seeing neurosurgery, I don't know if eventually they start them on it, but it is definitely not something that we empirically start in the emergency department.
Yeah, okay.
Yeah. But yeah, and then I guess with spinal cord injury, so like we talked about in the lecture, like the sign would be bradycardia and hypotension. And I don't know if you have this recommendation, but here, a lot of times their goal blood pressure is like a mean arterial pressure greater than 85.
High. Okay.
It's really high, yeah. So you have to start them on like norepinephrine or epinephrine, even if technically their blood pressure is normal. Sometimes you have to even start pressors just to make it greater than 85 MAP.
Yes.
Yeah.
Compared to adrenalines or noradrenalines, which you choose for spinal cord injury first?
I think I would choose norepinephrine.
Yes.
It kind of depends. I mean, you know, all the patients are different, but it's like if they're